I call this meeting to order at 6:08 PM. Madam Clerk, can we do roll call, please?
Director Burnworth,
Here.
Director Goodsell, Director Garcia,
Here.
Director Proctor,
Here.
Director Berger,
Here.
Director Bender.
Here.
Director Goodsell, did you figure out how to unmute yourself?
I think so. Thank you.
So Director Goodsell, only able to appear remotely, to observe, and she absolutely can weigh in on stuff, but just so you guys know, she can't count towards quorum and she can't vote on items, or her vote wouldn't count towards. Because she's not appearing under 82449 because she doesn't have any of the bases. But it's great that we have the option of remoting in just for basically observation like a member of the public.
Would everybody please stand for the pledge of allegiance? Ready? Begin.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Now we'll move on to item 5, consider approval of agenda. In the case of emergency, items may be added to the agenda by the majority vote of the board of directors. An emergency is defined as a work stoppage, a crippling disaster, or other activity that severely imperils public health, safety, or both. Items on the agenda may be taken out of sequential order as their priorities determined by the board of directors. The board may take action on any item carried for adjustments.
You have, so we need to remove that one. C. Yeah, 9C from the agenda. Remove. Yeah.
Are there any other adjustments? If none, I'll entertain a motion. I still move.
I second.
A motion by Berger and a second by Proctor. All in favor, say aye.
Aye.
Any opposed? Any abstentions? Motion carries. Now move on to item 6, public comments. At this time, the board will hear comments on any agenda item. If any person wishes to be heard, they shall stand, address the president, identify themselves, and state the subject for comment. Time limit for each speaker is 3 minutes individually per item to address the board. Individuals who wish to speak on multiple items will be allowed 4 minutes in total. A total of 15 minutes will be allotted. Shall be allocated for each item for all members of the public. The board may find it necessary to limit the total time allowable for all public not appearing on the agenda at any one meeting to 1 hour. Mr. Grass.
Good evening, members of the board, district staff, members of the public. Good evening. I'm here on behalf of the Pioneers Hospital Foundation. And just here to remind you that our hospital gala is coming up on October 16th, and you're all invited. As a matter of fact, we'd love to send you a personal invite, but we need your addresses. So that would be really helpful. We'll get an invitation out to you, or if you prefer, we just send it to the district email address if that's what you prefer, but we'd like to send you out and, you know, a real invitation. Also, just like to let you know that, you know, the evening is going to be from 6 to 9, involves dinner, auction, and so it'll be a night that's really fun. The foundation has set a goal of $500,000 to go towards the purchase of a new CT machine for Pioneers. So we encourage your support and getting the word out to anybody who can join us, and any donors who would like to donate to the cause as well. So thank you very much, and look forward to seeing you all there. Thank you. Thank you.
Do we have any other public comments? So none. Move on to board member comments. Did anybody in the event?
I did.
Yes.
Yes, I attended the first auxiliary meeting for the year of the season.
And, they reported, that they gave out scholarships. Gave out 7 scholarships and total of $5,000. And, they're going to be, selling the cancer awareness t-shirts in the gift shop this year. And then I reported just that this summer, the city had approved the asset transfer and that we were all in the process of moving forward. That was it. Builders?
I had a conversation with the electrical fire chief from Florida about the plans he's looking into better the electrical fire ambulance service and how IVHD will play a role with them. So I invited him to come and give us a presentation on our next agenda meeting. So I would like to have that on the next agenda. Have him present. And also this morning I attended the mass for the 9/11 victims, 7 o'clock this morning. And it was a lot of people, there was a lot of people there.
Yeah, that's it. I mean, I attended a funeral service that had the nurses honor guard, and that was super cool to see. I hadn't seen one before. It sounds like it's fairly new in California. It's in Arizona, so it's something very cool to see. We didn't have any like strategic meeting.
No, happy to give a short report, or I don't know if Pablo or Chris want to supplement. We are continuing to meet, with small groups. We had a pension group meeting this week, to make sure, items are moving forward. We had a regulatory meeting this week, to make sure that the child are moving forward. I sent the, regulatory work plan to the ad hoc and the checklist to the ad hoc, so they're aware of the many checklist items that we have to complete before the merger. And there's a strategic planning ad hoc meeting tomorrow morning. And there is a meeting between the deal teams, the ECRMC deal team, the Shepherd Mullen folks, our folks, to go through the checklist items and start figuring out, okay, I mean, the checklist is about 10 pages long. And it's stuff like, for example, real estate documents. Okay, do we have all the deeds? When are we writing them? Do we have all the environmental stuff? Do we have all of the, what's the progress on employee stuff? But so that stuff is moving along, and they're having a larger team meeting to discuss that tomorrow. And then we have a number of meetings set up next week too. So progress. Awesome.
All right. Anybody want to add? We'll move on to item 8, consent calendar. Any member of the board may request that items for the consent calendar be removed for discussions. Items so removed shall be acted upon separately immediately following approval of items remaining on the consent calendar. Do I have a motion? I so move.
I second.
I have a motion by Berker and a second by Garcia. All in favor, say aye. 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 Any opposed? Any abstentions? Motion carries. On to item 9. Items for discussion and or board action. Item A is resolution, approval of resolution number 2025-0911, resolution of the Imperial Valley Healthcare Board of Directors declaring vacancy on the board of directors.
Thank you, Madam Chair. I'll take this one. We received word from Director Madar that he, because of work stuff and a very busy schedule, he'd be unable to attend board meetings easily. And he's already missed a number of them and inconsistent with our policy, attendance policy, and in the health and safety code and in the board's bylaws. So we received today a signed letter of voluntary resignation from the board of directors. It's printed out for you, and it was delivered today, and we have copies for members of the public if they want to see it, because we didn't get it in time to include it in the agenda packet that's online, but we have copies here. The resolution that's presented, I brought a slightly modified version. Thank you, Brenda, for printing it. The version that's on your desk, and there's also versions available for the public. The only change is this in red below, which is to section 4 of the resolution specifying that the person elected to fill the vacancy shall be from District 7. So let me just talk through how this works. Because this is all governed by the government code's procedures for filling vacancies on a board. So first pass to fill a vacancy is this board appoints someone to fill the vacancy. You have 60 days from today to do that. If you don't do it within 60 days, then it gets kicked to the Board of Supervisors and they can appoint someone to fill the vacancy. There's different rules depending on how long we have until the next election, whether it's in the first or second half of that director's term. In this case, there's more than 130 days until the next general election because the next general election is in November of next year. And Director Medart is Director E from the AB 918 A through F list. His seat wasn't up until 28. So he was one of the 4 directors whose seat would be up in 28. So he's in the first half of his term. Election is more than 130 days away, which means you can appoint someone to fill his seat, but his seat will be up for election at the next general election, which is in 26. So here's how we can time it out is appointment happens by this board at some point in the next 60 days. That person serves until November of 26. In November of 26, the public elects someone to a 2-year term instead of a 4-year term. And then that seat is up again in 2028 when Director Medart's seat otherwise would have been up, and then we're back on the normal cycle pursuant to the first resolution the board adopted, setting the boundaries and setting the election cycle. So I specified in the resolution that the person who's elected to fill the vacancy in the election of 26, what district are they coming from, right? Because that's going to be an election, and currently districts 1, 2, and 3 are up for election in 26. So we specified that this appointed director's seat would be up from District 7 because that's where Director Medart currently lives. So someone from District 7 can run for that seat, be eligible for that seat, and run in 26. And then that person will serve a 2-year term. And then that seat will be up again in 28. So
Still from District 7 and.
correct, still from District 7, right. And I'm happy to show you, I have the map up here if you want to be reminded where District 7 is. That's this pink area here. And if you're curious, for example, Director Goodsell at Holtzville is in District 7 too, but like right now we have 2 directors who technically live in District 7, so nothing's going to change. It's still going to be 2 directors who are currently from District 7, but then that will get in 28, there will only be 1 from District 7. So happy to answer any questions, or if you want me to go through it again, happy to do that. Resignation letters here, resolution is here, and then we also included in the agenda packet if the resolution passes today, notice of vacancy. So we can send the statute requires us to send a notice of vacancy to the Registrar of Voters County Elections official, so they're aware. And then we also would publish today or tomorrow a notice of vacancy and call for applications if you want. So there's a couple different ways you can fill the appointment. You can bring back nominations. You have to publish a notice of vacancy for at least 15 days before you appoint someone. So you couldn't appoint someone at the next board meeting. Anyway, we don't even have a next board meeting in 2 weeks because of IVHD. So the next board meeting available to us is the 1st October meeting, which is about a month away. So perfect. We'll publish this tomorrow with plenty of time on the website. What I've done here, and you can direct me to do something different, this is just my idea, is inviting members of the public to submit a resume and a statement of interest by no later than September 26th, which would be 2 weeks from tomorrow, so that you can get applications, if you will, or statements of interest from folks who might be interested in filling the board seat. And then you can have another week to interview folks if you want to do a small panel interview, or you can bring those folks to the board meeting on October 11th or whenever the board meeting date is escaping me right now, and then ask them to give statements, discuss, and appoint at the next board meeting. You could take it upon yourself to have a one-on-one, take applicants out to coffee and see what you think about their fit with the board. You know, it is up to you how you want to do it, but if you want to call for applications, that's what the notice I have prepared is for statement of interest. It's just kind of easier that way. When they come in on, you know, it'll be cut off on December 26th, I'll forward that to the full board, and you can discuss at the committee level if you wanted to. I don't know if oh my gosh, I'm forgetting what our committee is called. That's like the outreach committee that we just formed last board meeting. That committee can invite the applicants to a committee meeting. You know, like there's a lot of different ways you could do it. So that's just for discussion and conversation. But you know, you may want to. So the only rule required by law is the person. Actually, they're going to be appointed, so you can appoint anyone. It could be from anywhere in the district, truly. The only rule for the election in 26 is that person has to be a resident of that district for 30 days. But otherwise, it's open season for whoever you think would be a good board member. Yeah.
Well, if I understand this correctly, so Director Goodsell is in the same district, District 7, right?
Correct.
So if the board appoints somebody, then they run for, that seat's up for election in 2026.
Right.
For a 2-year term. So in 2028, do we have potentially 2 individuals from the board running for the same district?
Yes, and that's the same situation we otherwise would have had with Director Medar and Director Goodsell. Yes. So, you know, you can talk at this point as a board and say, you know, we'll just entertain any applications that come in and talk about it at the next board meeting. We can have a special meeting in between if you want to have just a special meeting for interviews. It would be an open session because there's no closed session basis for it. You can form an ad hoc if you want a smaller group to be an interview panel and bring back a recommendation. And you can talk about, for example, I want to make sure it's someone that has healthcare experience, or I want to make sure it's someone who's from the tribe. I want to make sure it's someone who's from District 7. I want to, you know, or I don't want someone from District 7. I would rather have someone who currently is in District 1 because none of us live there right now, or, you know, whatever you guys want. But first steps first is approving the resolution and declaring the vacancy.
Does anybody have any thoughts?
Oh, got it.
No, you have a thought.
Everyone has that.
Everyone has thoughts. I think you should do resumes or application and interviews.
Yeah, I mean, the spirit of AB918 would be somebody from the tribe. But obviously it's something we can take into consideration during applications.
And they also have the opportunity to apply well.
Yeah,
Absolutely, yeah. And we could, if you wanted to direct me to solicit, like to contact, and perhaps this is something Director Medar can help me with, is like whoever the head of the tribe is, I can send the notice of vacancy and call for applications and say, please circulate this through the tribe. We're interested in, you know, interested applicants. But like I said, anyone from the county could apply.
I like that, to direct you to do that, and that's a whole spirit, I mean, it's a tribe seat, you know, and then. I mean, you kind of, I feel like there's no win in this situation,
Yeah,
where we're being honest, you know, like,
Yeah, Director Medar was a great director too, so it's really,
Yes, he was.
so. Okay, so. Do we want to? Obviously approve this resolution.
maybe that's the first step. Is just approve the resolution, and then after the resolution, you can give me direction on how to proceed. to prepare for next board meeting.
I so move that we approve this resolution to fill the vacancy.
Second.
Have a motion by Burker, second by Valdez. All in favor, say aye.
Aye.
Any part.
Any opposed? Any abstentions? Motion carries. And so direction would be to get that posted.
Direction will be to send out the notice of vacancy, which would be sent out by Katie, Director Birdworth. So I prepared it for her signature, and then I'll get her to sign it tomorrow and send it out. And then I'll coordinate with Chris and Frank and get this notice of vacancy and call for applications on the website. And then do you want to direct me to send it to someone at the tribe? Okay. Yeah. someone at Tribal Council. Okay.
And what is the deadline?
The deadline is September 26th, 5 PM. I have them coming to me directly. So I can package them, put them together in a like bookmark PDF and then circulate them to the board. Do you want to have a special meeting between now and October? This is gonna drive me crazy. I have to figure out what the date is.
9th, October 9th.
9, thank you, Chris. Between now and October 9 for the sole purpose of interviews?
Sure.
Okay. So we're gonna have the applications by October 26th. The week of the 29th might be a good week. Is that,
Over 26 or September 26?
I'm sorry, September 26th, 2 weeks. We're giving folks, because we want to try to fill it relatively quickly. You only have 60 days.
Second,
Oh, is that that?
Yeah.
Okay.
I actually can't work. I have another in-person meeting at 4, so the
was,
3rd I could do, or the 1st.
was it first?
Okay. October
Wait, no,
1st.
I count that day. Okay. that's good.
The 30th, I could do the 30th.
Yeah.
Yeah, it's good for me.
30, 40.
Okay, September 30, do you want to pick a time?
6 PM.
6 PM? Okay, September 30, 6 PM. I will, I'll add that to the call here. It's just say, applicants should be prepared to appear at a board meeting on a special board meeting, September 30 to,
Where at?
you guys can.
Good old Central.
Yeah, El Centro Regional, yeah. Okay. See, special meeting. And I'll coordinate with Brenda to get that agenda.
6.
September 30, 6 PM. Okay. And I'll offer folks the opportunity, if they have work or whatever, I'll let them know that we do have like Teams options, so maybe they can zoom in, if they can't be there in person, but I'll let them know that in person is preferred. Okay, anything else?
If you can put an emphasis on, in-person's preferred, just to make sure that we're able to make evening meetings, what have you, just not that it's an option.
Right. Yeah,
And it specifies on that it's, would be from whenever. till-
yes, it says here that the individual appointed, the board will fill the vacancy by appointment. The individual appointed will serve as IVHD director until the person who is elected to fill the vacancy at the next general election has been qualified. That's the November 26th election. And then qualified just means they have to get sworn in. So I don't want to put the November 4 date because that's technically not when they start their service. They have to get sworn in at the next board meeting after that. So yes, that is on there. They know that it's going to be about a roughly 1 year-ish appointment. Okay, I have my direction. Thank you.
Ready? We'll move on to item B, approval of shared services agreement between the Carroll Valley Healthcare District and El Centro Regional.
Yes, I'll take this one to, Doug Big, my, our friend at ECRNC, General Counsel, and I, conferred about a shared services agreement, and I know staff has conferred also. So this is an agreement that puts pen to paper on the two hospitals sharing services, staff, creating overlap, sharing records, really preparing for the merger. The list of shared services, which is practically the most important part of the agreement, is Exhibit A. But this is an important document for example, HIPAA compliance, BAAs, legal privacy reasons, to make sure we have documentation allowing folks to share records without breaching any laws, privacy laws. So the services, it's intentionally very broad. I know Chris and Pablo work together on this to coordinate on these shared services. So we've got finance, HR, quality and education, pharmacy, laboratory, hospital, clinical services, outpatient clinics, IT, facilities and construction, medical equipment, med staff, compliance and risk management, marketing and patient experience. And then a joint BAA is attached so that we can have that. It's IVHD BAA is our split. But I'm happy to answer any questions. And this really is sort of what we've been trying to do anyway. Like, this is just solidifying that, formally.
I do have a question. So Pablo or Chris, I know you guys have been working together and we've talked about Cerner in the past and how's that coming along, having the different types of Cerner, if you will.
It's coming along. We still have to get the IVHD part taken care of for the first child that we're working on. And that should happen here at the end of this month, first part of next month, that kicks over. Or actually, excuse me, it is this month, but here next week, I believe. And then once that happens, we start the process of what that will look like with ECRMC. And then ECRMC will most likely have to come over like we did initially, because that part will be a little bit easier as far as the changes that have to happen within theirs. And then the bigger piece of that is when it all comes together and we're technically under one. That lift is pretty extensive. So we will be running, two different instances of Cerner for a while until we can get to that point, and get that switched over. Cerner still isn't sure how they'll make that work or what that will look like. And then the other component of that that's probably even more touchy is the contract portion of it, because we have two separate contracts that have two different timelines on them as well. And so taking those two and turning them into one is going to be another piece that we have to deal with as well.
We've been talking to Cerner about that.
Yeah.
Like a budgeted amount for this, or, I mean, we both have our budgets, right? But I mean, as far as I'm concerned, I really just don't want to get handed another $10 million bill from Cerner for doing this
Right.
reconfiguration. So I would really actually like to pay an amount that we're going to be spending.
That's the piece that they're working on right now, because they have to figure out what the full scope is to make that happen. Like we had the amount for us to do the name change, right? We'll get one of those for ECRMC as well when we get to that point. And they're still working on that scope of what that looks like for the full thing. And then once they have that scope is when they give us the dollar amount associated with that, which would be probably, if I had to guess, fairly similar to a go live implementation.
Was there any budget amount? Like, did we budget anything for this?
It won't be in this year. It would be next year budget before that hit.
I guess I'm kind of concerned because, we're talking about a merge. I mean, I've moved from one house to another. I know how expensive it is, And I know we have our budgets, but I really truly would just like to have a true picture, even an assumption. You can give it to me, of how much you would think this whole merge is gonna process, because, we're both kind of distressed, and we don't know what's gonna happen with the big ugly bill. But then also too, I think that as far as, just the financial stability of the merge and the two facilities. I think we need to look very closely where we spend our money from now until that's done. And then at that point, we can make a decision where we're gonna spend money. But I really think that at this point, we need to be cautious.
I think Cerner needs to provide the options of what they could do and how they could do it, and then you could bring that back to the board for input decision.
I mean, we're kind of in hard spots because we're merging, you know.
Yeah.
But we have to look at it. Us.
And originally, we had tried to look at creating one system for both hospital, but things were not going the way the merger was going, so that didn't happen. So now we have to deal, IVHD has a 10-year agreement with Cerner. We have a 7-year agreement. Now it's 9 and 6 for us. Originally they wanted to create a new enterprise, which doesn't make any sense. But we will have to explore with them more of what it would look like and the steps and bring it back with costs.
Yeah, and also,
Because there'll be costs associated with it. They're not gonna do it for free.
and you know, even with our implementation, I mean, they're still nickel and diming us to this day, you know. So we're still spending millions, so I just want to be very cautious. If you could do.
Right.
So could they have originally built one for both hospitals?
So we were talking to them about perhaps building one for both hospitals. But we had meetings to explore that idea, but then the boards said no. We were gonna move separate,
Which boards?
both boards,
You know,
our ECM.
No, not you guys.
And the other board.
oh, the previous board.
Yeah.
Yeah.
Another decision costing us millions.
Yeah. Mhm.
Thank you.
Thank you, guys. That's frustrating.
I do feel that this shared services agreement is late. I think it should have been done a while back, you know, just to make sure that things are seamless and get done correctly as we move along in this transition, so. And you guys have any other questions?
Yeah, it's a step in the right direction. It's gonna make the transition a lot easier for everybody.
Definitely.
You know, if we can start saving money now, like HR, I know we don't have a CHRO, you know, and that's something we're gonna share, like that's an immediate cost savings, you know.
Gonna give us a good financial picture as well.
Do you have a motion? Any other questions?
I so move that we approve the shared service agreement with Health Central Regional and IVHD.
I'll second.
I have a motion by Parker and a second by Garcia. All in favor, say aye. Any opposed? Abstentions? Motion carries. Now we have item D, policy and procedure for breastfeeding. I just have a question. So I'm looking through this. And it was updated in May. But then looks like it took a really long time to get approved by the department. And then to finally make its way to the MEC. So it got, was revised in May. Made 6 feeds in OB in July. And then the rest in August.
So sometimes, if they reschedule a meeting or they canceled, then it gets fixed to the following one. And I think with the OB committee, they might have, not had one where it was rescheduled or canceled.
Okay.
OB committee meets quarterly.
Yeah.
Yeah.
Okay, because I have the same question on the next item, because it's like, it was revised in November of 24, the PSQC approved in December of 24, MSQC in April, MEC in April. So,
Yeah, that's usually what ends up happening, or say like if they have revisions, recommendations, which the, I believe it was the PI one, actually, I think at MEC level, they had some questions about it. They wanted us to revise some things on it, so we went ahead and did that and then we submitted.
okay, so then it has to go back
Yeah,
to the MEC.
sometimes, if they tell us what the revisions are and, you know, I'll say, okay, can we make the revision? And then, you know, can it be approved with knowing that that revision was made? Most of the time they'll say, yes, that's fine, but in some occasions they'll want it to go back or to go through the whole approval process again.
Okay, so the dates might have been later than what's on the policy. And then just FYI, on the QA PI, it still says primary Memorial Health Care District on the,
It still has it on the, is that an attachment?
yeah,
Okay,
on the sheet.
thank you.
That's all the questions I have on the policies. So if anybody else does wants to make a motion for.
I'll make a motion to approve, item 9, D, E, F, G, and H.
A second.
A motion by Proctor and a second by Berker. All in favor, say aye. Any opposed? Any abstentions? Motion carries. Now move on to item I, agreement between NTC Medical LLC and Imperial Valley Health Care District. That'll be your first.
That's the detention center agreement for the sexual assault, nurse exams. It's, doesn't cost us anything, and the pricing there is for when they request an exam, that's what they're gonna be paying us. Since we've got this contract, we've actually haven't had to do an exam for them. But at least, so they need to have it in place, because of law for them. And the other two are, school affiliation agreements for physicians, for PA school. And I didn't realize I didn't have to use a board item where I could just report it during my DNR report, but that was clarified to me. And I think those are it.
Okay. I, Jen, okay. Any questions? Or motion?
And I so moved that we approve IJ and K.
You have a second?
A second.
A motion by Berger and a second by Proctor. All in favor, say aye. Any opposed? Any abstentions? Motion carries. Now we move on to item L, discussion and action regarding future open control facility naming and branding.
So the original plan was to bring you guys some options today to be able to look at and go through. In the process of going through the name changing and looking at options and revisions, one of the things that came up was that anything that we do from this standpoint, like, you know, we could all, as a board, you guys could look at whatever it is that we bring and say, oh, you guys really like that one. And you're gonna say, everybody's on board, everybody votes for it, and that's the name you go with. We're still gonna have some people that are gonna be like, that's ridiculous, why would you name it that? We're gonna have that kind of stuff that happens. And so the thought came to mind that we could involve the staff at ECRMC and give them a voice on that and have those recommendations then come to the board And then they have a piece in what comes to you guys, for approval, the, 3 options or something like that. And then you guys can choose from there. And they can say they had a piece of that, a part of that and go from there.
I think, I'm saying my biggest thing is like, we need this for like the chow and the regulatory right now. And then it's like, it puts us in a hard spot. It's like, hey, staff out of this one, we're like, well, that one's awful, but we're the board, so you don't get staff.
And yeah, and I think that we discussed that we were gonna leave it to staff, so all this time staff. And now there's, do you have any suggestions? Or did you contact with staff or?
No, we had our marketing meeting today, and Matt told me that he's got a memo that will go out to the staff once Pablo approves it. I don't think he's given it to you to look at yet. And it's set to go tomorrow.
Can we bring that back to our special meeting? That way we can.
But like, I mean, I don't know. I think I think that puts the board in the dark spot.
It does.
So there were, I was involved in the original conversation, so we've heard about the name changing about a week and a half ago. And I said, well, I want to be part of that, and I want the staff to be part of that. There were a couple of suggestions. There were 5 suggestions that were made. And we had a exec team meeting and brought those suggestions to the executive team meeting. And, as you tell, everybody had a different opinion. One of the names that there were 2 naming that were provided. One was Imperial Valley Hospital, which kind of goes with the IVHD part of the Imperial Valley Healthcare District. And then the other option was in Valley United Hospital, which
Union buildings.
yeah.
Reminds me of the car dealership.
Yeah. So I think that the option that people liked the best in our team was the Imperial Valley Hospital. And we were gonna send that to do a monkey survey monkey, and have our staff have some input. Because I think it's going to be very emotional. No matter how you look at it, changing names and changing identity, and, that is going to be a little bit harder for the staff to be told, this is what you're gonna be told, and they would not have any participation or anything. Not that they're gonna make the decision.
I'm not really concerned about the decision. I'm just concerned that the last board meeting, I think we gave directions to leave it up to the staff, and then wasn't it, Brenda? It's in the minutes, yeah. Yeah, the last meeting, yeah, a couple meetings ago, and then all of a sudden, it's just like last week. And then we're in the middle of this transition, and we've got to have a name, and we've got to get all these regulatory papers together, and I just really feel that. I mean, it's not like a huge issue, but it is a big, huge issue because you have to register that name. So I'm just like, really truthfully trying to put in constraints on our timeline. I don't know.
I mean, you could even say the
How do you
same.
guys feel?
Imperial Valley Central Hospital.
Oh, was there any discussion about leaving it the same?
Save money on fine.
Yeah, there was discussion about that. So that is an option.
I mean, my My kind of thoughts have always been like, you have the two hospitals and then like the clinics, everything else to be in Imperial Valley Healthcare District. Like that's always kind of been my thought process.
It's saying leaving the El Centro Regional the same. So.
Like, or you have, whatever your two hospitals, we have Pine Ridge Memorial Hospital, but eventually like all the rural clinics and everything will just be Imperial Valley Healthcare District.
System, yeah.
Yeah, be the healthcare district and then the hospitals, I think, looking at the, I mean,
So the Central Regional Medical Center, that entity will cease to exist.
Right. But you could, I'm just saying, the DBA could hypothetically be El Centro Regional Medical Center, just like how we did from Pioneers Memorial Healthcare District, we just Pioneers Memorial Hospital. You could do El Centro Regional Hospital or El Centro Regional Medical Center could be the name, the DBA. Because right now, our current license with CDPH says, like the license holder is Imperial Valley Healthcare District, DBA PM, Pioneers Memorial Hospital. And so the chow for this, the change of ownership documentation, and there's a lot of different like permits and things like that we need to identify who is the holder of the permit. It's Imperial Valley Healthcare District doing business as what, and so we just need the what, because there's about 20 different things we have to submit, and we can change the name later, but it's a pain in the butt, so might as well do it now, then do it once and do it right. And we want, especially the chow has a long lead time. That one is like 100 days. And we could do it faster than that. We believe that it will get done faster than that. But, that needs to be submitted yesterday, ideally, right? So, but.
And the marketing team that initially went through and did the first crack at it. That was part of that discussion, was because of how things are changing within the valley, right? And how we're changing this. The discussion was not to have a hospital with a location name on there, so that it's not saying that this belongs to El Centro. We want to make sure that everybody knows that it's the whole county's hospital, not just El Centro's, not just Brawley's. We didn't want to put the name, but that was the thought process behind what we were trying to, like, when we were, like, none of the options that we had presented had the name El Centro in there for that reason. We wanted to be, we wanted it to be indicative of the new change and that this hospital is for everyone.
So how does the board feel about Imperial Valley Hospital?
I like Central, but Central doesn't mean El Centro. It just means center of the valley. It's the Central.
I think they want to get away from Central.
yeah.
Maybe it's the Spartan in me.
Actually,
No,
those considerations came in and
Yeah.
in our word cloud, the Spartan was in the word cloud.
So
What about the Valley Regional
Oh.
Medical Center? The whole valley keeps it looking for the old
Valley Regional, like that.
Imperial Valley Regional Hospital.
Valley Regional.
Valley Regional.
We're trying to get away from medical center and stick with the hospital.
Yeah,
To be more,
hospital.
there's a better,
yeah, not that I'm opposed to Valley,
Valley
Valley.
Regional Medical Center.
Valley Regional Medical Center.
and then that's the other piece too, like that was one of the reasons why we wanted to take out regional as well. Because again, it's indicative of
Just
geographical,
Yeah.
and if you're saying that, and there's the other hospital too, that's technically the same region. It's, so
Real county.
Finance Valley Hospital.
Imperial Valley Hospital.
I like that.
Yeah. Yeah. The one piece on that too, and I'll throw this out there because we had the conversation again with the marketing team on that. The one part that's different on there is, and we can change this based off of the next step, right? So keep that in mind. That would be where that would happen. But like right now, if you're putting that on letterhead or you're putting that on a t-shirt for the hospital, it's going to be Imperial Valley Hospital, Imperial Valley Healthcare District. And so it doesn't exactly like, and so that part, like, there's a lot of redundancy there. But the conversation was when we go through that, like, we can do that. And I think we can definitely do it. But I just want you to guys keep that in mind. Because the next phase of that in the conversation is now that we have, once we have the name, that starts that full rebranding, right? Because remember, we had talked everything as a placeholder, and what we did with Pioneers was a soft rebrand. And so we would do a full rebrand at that point in time. And then the idea would be that you have a logo, and that logo is what's indicative of Imperial Valley Healthcare District. And then you can put the logo and then Imperial Valley Hospital, and you put the logo and Pioneers Memorial Hospital. And the logo is what lets everybody know and ties it to it. So you can put that at the front of everything. And then that's how that can play out. There's hospitals that do that as well. So that would be a way around like the redundancy if we go that route.
Branding is big, like branding is huge.
Right.
Well, we can have a naming conversation today if you wanted to make a decision and then a branding conversation in the future.
Yeah, that's yeah.
And Patty has-
Yeah, we have a question or a public comment from Patty Mason. Patty, do you want to unmute yourself? Can you try again? No, because I'm testing it out here too.
Out.
Laura, can you try speaking?
You're muted, brother.
Hi,
That's not the speaker.
can you hear me?
I can hear you. Thank you.
You're welcome.
We can't hear you. I don't know if it's your speaker. But you're welcome to call in. Or you could call and I'll put you on speaker from my phone.
He wants to discuss more the branding.
Oh, the branding. Okay.
You know, I think probably we just go with the timber effectively and then decide on the branding here. Because how do you feel about that?
But that has to be the like.
Yeah.
And that's a
Either
big
don't
step.
do it or do it. Yeah, I
Yeah.
agree. I think either like pick a name now or
Yeah.
don't and then pick it later and we'll just submit.
Oh, yeah.
You know, if we need to submit with the TBD or something, we'll figure it out.
So I hate being in this situation. I'll tell you why. Because when we were very intimate with PMH, with that hospital, the community, giving them ample time to have a lot of robust discussions about maintaining the identity of that community, which is connected, at the hip with PMH.
Right.
And I just feel though, right now that we're kind of stripping that of the El Centro community and because we are where we are. And I wish that maybe that community was more voiceful about speaking about, this issue, because at the end of the day, the people that work at those people, the ones that are gonna change the name of us. But I do understand that we have to make a decision. But I'll do as the board decides.
I recommend that we don't make a decision, and that we come back at perhaps the next meeting once we vet it with our staff and other folks. And bring a recommendation or stay with the Central Regional name on it. Change it at a later.
I think that we should just keep it at medical center for right now. That's my feeling too. Well, I don't know how you guys feel about it.
So the next board meeting is October 9th, and then we have a special meeting on September 30th. So do you want to direct us on when to bring it back?
I mean, I don't want the branding is big, like I don't want it to be rushed,
Right.
and
You can just have a name conversation and not the branding, or you can do both at the same time.
The branding has to come to second. That'll take a while, and that's going to be more robust conversation too.
One of the challenges is like Pioneer that kind of gives, and it has an identity with Raleigh, right? And
Mhm.
Health Central, like what is the identity there other than Spartan?
Okay, can you hear me now?
Yeah, we can.
Can you hear me now? This is Patty Mason.
Raleigh, in a sense, you know?
Yeah, we can hear you, Patty. Go ahead.
Okay, this is really actually an important decision. And I know we need to get names on the chows and things like that. I mean, it's actually kind of difficult to change it once you once you do that. So if you can kind of land on it, you know, some of the industry standards, and something that we've done and Sharp and Scripps as an example is you just, you know, you can be Imperial Valley Health. And then you can be every setting you name, Imperial Valley Health, you know, Pioneers Hospital, Imperial Valley Health, El Centro Regional, Hospital. You know, you your tagline is Imperial Valley Health, and your clinic name can follow that. Your hospital names can follow that, so you can identify those local communities as, you know, the different settings under which Imperial Valley Health is operating.
And we did look at that. And there's already an Imperial Valley Health. Somebody's
Who
already
has it?
using. The
Well, local, our current license of Imperial Valley Healthcare District, you know, DBA Pioneer Memorial Hospital. So
It's just-
I think.
The
what we were
hospital
thinking
name
is-
shouldn't be a district from a brand perspective. But again, I'm jumping in the middle of this, and I think actually you need to do a little bit more work on it, probably.
Yeah, definitely.
I like that Central Valley Hospital idea. It's a good.
Middle.
Especially.
Some Bakersfield.
Yeah, Central Valley's and.
Bakersfield.
We just have to make a bigger name for ourselves.
I mean, I think, well, like, I think like Pioneers, like, okay, Pioneers of the Valley, like, what's another piece of it? Your culture, your heritage, something like that.
And that's one of the things that we, like the marketing team had discussed as well. Cause like right now, if you have like one name, you say Pioneers, everybody knows that's the healthcare, that's the piece. And so if you can do something similar to, with ECRMC, if you can have something like that, that people, you say that and people are like, yeah, that's the healthcare, that's IVHD. That helps too, from that branding standpoint. And so those are, I mean, we had a lot of robust conversation about it. There was a lot of wordsmithing and word clouds and a lot of things that came to be. And so there was there were a lot of, like the Imperial Valley Health, when we're like, oh, that's that. And then we're like, oh, wait, somebody's already got that. And we do another name. Oh, somebody's already got that. And so we went through a lot of that process as well. But with the thought process being kind of, I guess, like to Arturo's point, like if we're involving the staff in that process, then they're part of it. You can have ownership in it at that point in time, right? As a staff member saying that I helped with that process, I chose, and went through some of that. So there's value to that perspective, to that. So that's why we ended up where we're at.
Frontier Hospital.
Hmm?
Frontier.
I'm still with Central. You didn't go for my.
That one did not.
We need to bring it back.
That, yeah, we can.
We can still make it work.
So
I
bring it
do,
back to
I
October
don't
9th.
like, I will say I don't like memorial in the name.
Yeah.
And it's nothing against Pioneers. It reminds me of people dying. People
Right.
go to the hospital to get,
You have to have something that is memorializing, right? You have to have something that you're memorializing.
yeah, I'm not a fan of that. Just
I agree.
my two.
I do like Central Valley Health, though. I do like those together from.
Yeah.
I wonder if historically, if there was another hospital in El Centro had a different
It
name.
did have a name before, El Central Regional. It was
Yeah.
something different. Like
Central Community.
Also the community.
That was my question too. What was it before in the beginning?
Like Imperial Valley Health System, I mean, El Centro campus, like something like that. You
Yeah,
know, we
that's
call it the
what-
Pioneers campus, El Centro.
Oh, yeah. I like him.
I like that as far as like Imperial, I mean, like Sharks Chula Vista and Sharks Rosemont, you know. I like it because it adds that location, but it's the IVHD or Imperial Valley Health or whatever.
Bring it back.
Okay, October 9 or September 30?
I was thinking you need it. I mean,
Can,
The sooner the better for our purposes, but I also don't
Let's do-
want to rush. It's your decision.
Let's do September 30.
Is that
enough
okay
time
with
for
you?
you guys?
Yeah, is that enough time for you, Pablo and Chris?
Yeah.
Is that enough time for you, Matt?
Yeah.
don't,
Yes.
yeah.
Yeah, that's 20.
Hey, Matt, you could tell them that if they don't pick, it's gonna be Pioneer South.
You'll start to get, you'll get people moving.
Sus.
You can tell them somebody floated the name Wildcat, I don't know.
Yeah. The word cloud is getting more robust and that I appreciate that. So.
Thank you, man.
Thank you.
Nice.
Right.
So.
$908 transfers, that's 2.97% of the ER admission, of the ER visits that get, transferred out. I did, sorry. It's not part of the report, but I did go back and I looked at, the inpatient, that had been transferred out based on our CNO report, which goes out, per shift. And I did see that we did have 100 inpatient transfers. So that was 41 to Scripps, 22 to UCSD, 7 to Desert, 6 to Arsenic, and then 8 to other long-term care facilities, and then 20 to Raythe's. And the reasons for it is, as you see on the transfer report, for the pediatric cases, the majority of them were respiratory. And then GI, there was cardio, a lot of cardio, and then some labor and delivery for those cases, usually like preterm labor, greater, like earlier than 30 weeks being transferred out. And so I did also want to share that with you in the future. That will be part of the report. And then the other thing I wanted to highlight was that last week we started with the UCSD, the UCSD telemedicine intensivist program, which they're providing telemedicine services from Friday through Sunday. Currently it's from 7:30 to 9:30. It's 2 hours. They started slow. We've had a meeting since then to kind of iron out some of the things that we identified that we needed to work on. And it mostly has to do with the handoff report that we're doing with the two intensivists and the nursing staff, and then cardio as well. So that is going well. And the other thing I wanted to share from the report is the patient experience. You can see there for August 2025, our overall is 74.6%, which is a little bit better than in July. And then communication with nurses and communication with doctors has improved. We're doing a lot of work with the staff to increase the rounding, increase service recovery, we implemented hourly rounding, and now we're just making sure that the staff is doing that hourly rounding. And then we're reinforcing the quiet time, with some of the feedback we're getting, is about that. And then we're having discussions with their teams about professionalism, what the community sees as far as, being professional, being quiet, being respectful, what there's, being on the phones, watching videos and those kinds of things. So we hope to see improvement there as well. Do you have any other questions regarding the dinner report?
I had a question on the total, the 908 that is from.
I'm sorry, what was that?
The 908 total transfer, is that from the ER?
Those are your,
Okay, and so the 100 was,
what's from the inpatient side? Yeah, they were already admitted and then they have to be transferred.
And those, that was that in the month or was that?
Oh, sorry, I forgot to mention that. So I went, I looked from January 1st up to yesterday.
Okay.
Yeah, or yeah.
and how are your transfers going?
I haven't heard any more concerns being recognized as far as script. And with Desert, things are just getting better. We did have a meeting, as I think I mentioned it last time, that I did have a meeting with the team a couple of weeks ago from UCSD regarding the transfers. And so there's only been one issue, which I reported last time, that we escalated to the team and it was addressed. And they didn't refuse the transfer. It was more, there was a little bit of a delay, so we needed to address it.
And I had another question I was gonna ask you the last time. And do you ever go back and look at the outcome after you transfer?
We don't do it consistently, but we have done it in the past. Like if there's been, most of the time it's quality related. Say we were trying to transfer the patient out and there was delays, we go back and look. Or say, there was like a dispute on whether that patient could have stayed or, gone. And because they're saying like, well, we don't have the services here, or that's higher level of care. And then to find out, they send the patient back and said like, oh, we could have kept the patient here. Those cases we have reviewed. There haven't been a lot of them. I don't recall if I mentioned this last time, but Dr. Guan is actually helping us review those transfer reports where with the clinical details. And so we're looking at that.
Yeah, but she's just looking at if they should have stayed or they should have gone. But I would be interested in knowing the outcome of that patient care that you transferred that patient to what hospital? Because I mean, really and truthfully, depending on the outcome of where you're transferring the patient to, I mean, I know we have to transfer the patient, but I just want to make sure they're getting the best of care as well, wherever you transfer them.
Yeah.
Is that a HIPAA violation? Not our patient anymore?
To kind of, I mean, we have a process where we could do that, but again, it's usually a quality, like, there's a quality issue that triggers it. So to just want to find out like, hey, was care great or not? It's not something that.
Maybe you could do a survey with the patients that you transferred. And yeah.
Can I add into that? So that can be done, that should be done, part of the quality and the PIP team, is that there's a transfer of care coordination that's between the hospital and the PCP. So as long as that patient is a PCP, that transfer of care is coordinated back and forth between the referring facilities and back with the PCP. So to her point, it's really hard for us to get a quality report if it's not our patient. It's a lot easier if we're the PCP for that patient. Then you can certainly have a quality review where you go back and touch base with the PCP, the provider, to validate whether or not that care was appropriate, and then make sure that the follow-on with the transfer of care is appropriate as well. But if it's not our patient, it's extremely hard.
And that would be possible if you were in the same EMR system, but all the facilities that we transferred, well, a lot of the facilities in San Diego are in Epic.
Yep.
We're in a different system, so it makes it a little bit tedious to find all the patients that were transferred out.
What's the question?
We're talking about,
You do.
300, 400 patients a month that we transfer out of here, which goes back to looking at our migration and part of the strategic plan that we're put together.
The health plans require us to do it for our ED discharges and our patients for PCPs. We're required to do that as part of our quality measures with them. But to her point, the transfers out of the system, those are great.
Right.
That's
Oh, no. Laura said they can't see the savings.
I'm just dancing now so much yesterday.
Thank you, Carol. And then Patty up for generation.
Can you hear me this time? Great. You know, in terms of the transfers, it's a little bit more complicated than tracking because certain patients have to go to certain centers because of the services that they provide. For UCSD, if we don't take a patient right away, I'll give you an example. Today, we had 70 patients through our EDs that were admitted and we're waiting for beds. And we have to not take transfers until we can start processing those patients. That's the level of demand that we have. If you have someone that needs a heart transplant or a lung transplant, they have to come to UCSD. And so it's kind of an algorithm you have to think about. We don't need to take every transfer. That's not what this is about. It's actually more about, to Pablo's point, building the clinical infrastructure in the valley so you can keep as many of those patients there as possible. When they have to come out, you should be able to track and make sure that they end up in the right location to provide the services that you need. It's just, I guess my bottom line point is it's a little more complicated than just kind of looking at all hospitals like they're all the same and they're providing the same services, because they're not.
Right, I understood that. You just asked a hypothetical question.
It's a good one. No, it's a good one.
Thanks. Does anybody else have questions for Carol? Then we're on to Carly Zahora.
My report is in the packet. It's pretty long, so if you guys have questions, please let me know, but I am gonna take notes to a few things. In the last board meeting, I talked about the MRI tech. At that time, we had our last offer out, but unfortunately, they accepted. So we're still looking for somebody, and that's for our per diem MRI tech that we utilize on the weekends to help us get our business. So we're still in the search, and I believe ECMC is as well. Both kind of the same thing. We did start this week our annual health fair with lab and with employees. So employees are going through getting their labs drawn, their flu shot, and their tuberculosis testing. So that started this week. It's been very busy. So that'll go over the next month. I do want to take note to 2 lines of services that which is pediatrics and OB. We have gaps in coverage till the end of the year. OB is about 2 days a month. Pediatric is about 14 days a month. So we are looking for locums. Yeah, so that will be a financial impact to the organization. So there is conversations going on with the pediatricians and the OBs to try to see how we can mitigate that. But I did want you guys to.
Is there a reason that the OBs?
OB, one provider takes, a couple of providers take a lot of call and it's becoming overwhelming for them. So they decided to take a couple of days off, which impacted nobody else is available to cover. Pediatrics is kind of the same thing. There's 2 pediatricians that have been taking the full coverage and one of them would like to take a step back.
Oh, no.
No. Don't we have like certain, like in the OB doctors contracts, like isn't there certain days where they like have to take calls how many days a month or?
No, it doesn't really specify on that because like within the bylaws actually read that if you're going to receive privileges at our hospital, you're supposed to take a third of the call. And not everybody can take a third of the call. And so it should be something that's equitable. And that was part of the conversation that we had with some of them. We've had a couple of conversations with the different groups. We have 2 more of the different groups that are OB related to have that conversation with. And some of them, that's what it is. They're like, well, I do X, Y, and Z, so I'm only going to take 2 days of call, 3 days of call. And others who are taking more, like we had one that was taking way too much. We're like, you got to cut back. You can't take that much call. It's just not okay. And so like we have the numbers in there, but when you have the conversation with them as well, they're telling you it's pretty, like they're tired, they're burned out. What really needs to happen is we know we need about 2 or 3 more OB/GYNs in the area at least. And that will help because that will also help spread out the number for call as well. And that's just the issue running into. They're in the past, there hasn't been a lot of, the way that it was explained to us by the medical director for that is they didn't do it by people, they did it by the groups. And so there are 4 different groups that are doing it. And so each one of them were supposed to have 7 to 8 days. And then some of them that wanted more, they could give their days over. And then they would put out the schedule for the months ahead. And then in this case, we had somebody who was taking way too much call and is saying, I can't do that. And we agree, he should not. And so then that created holes where everybody's like, hey, I've already kind of like was planning on not working on that day and not doing that. So we're working with the others to see if we can get them to fill it, to be able to do that. But it is not like 100% equitable at this point in time as far as by the group. So that's the part where we're having those conversations right now to get it fixed.
Maybe that explains the higher than national average C-section rates.
Partially, but it's also the acuity for those in our area. We have a lot that actually, like they gave us an example of somebody who showed up for 42 weeks, hasn't seen a doctor at all, and, you know, has complications, is obese and so on and so forth. And yeah, so we have a lot of like really high acuity from that standpoint, which adds to that. Not necessarily so much like the call factor of it, but we have other issues there for sure.
Yeah, but I mean, it's just very apparent that there's a lot of issues going on in the OB department.
So, Carly, the PED support team, I mean, that's a good thing, right?
No, that's just a call. This is all.
That's a call coverage, yeah, not in the clinic.
Yeah.
Yeah, and I'm looking at the clinic report for the no-shows. There's a lot of no-shows in
There is, so right now, we're actually looking at, how East RMC have structured our no-shows at Cerner so that we can try to align. Because as Cerner is showing that we're about 12% no-show overall, but when we manually do it, it's a little bit higher, so we're trying to figure that out. But we do have a high no-show rate, especially in our Calexico Health Center. So right now, we're having the conversations with the providers on kind of increasing, you know, their volumes on that day to account for the no-shows, and actually talking with the staff about those reminder calls. And then our QIP team on calling those patients to make sure they're getting back on the schedule and why they missed their appointment. You know, with Notable in place, you know, it reminds them, but I'll give an example of 2 of our weekend clinics that we had kind of focus on our quality metrics for OB, even had the Mano Tech available that day, and out of 28 patients, only 6 showed up. So
oh, wow.
It was a really, really high no-show rate. And they all called, they all answered, some verified that morning, and they still didn't show. So we do have.
Was it like raining or something?
No, it wasn't hot.
It was hot.
It's probably hot.
But we're trying to think about different ways.
Yeah, because I just like.
Do we text message also?
They
That's part of the normal process too.
It makes you confirm your findings.
Yeah.
And the coverage is a managed medical. Yeah,
Plexico is systemically a hard place. You
very hard.
get people to come in.
And I will talk about our centralized scheduling. I know that's a topic. We've done a lot of reviewing, adding extra FTEs, taking them off the floor to see how we can, you know, make it better and find those gaps. So we did put some individuals, I believe I talked about it all the time, on the nurse line, because half of our calls are going to the nurse line. And I think it's because they hear the word nurse and, you know, they think they're gonna get a live person, right? So majority of those calls were not nurse related. It was either referrals, authorizations, medication refills. So instead of having that nurse line specific with a nurse, we're gonna take it back into the calls where they would make that appointment. So we were able to hire a couple of extra staff. Those calls will go back on there, which will kick it back into the system where if, you know, they don't want to wait in line for somebody to answer, they're automatically gonna get a call back. They can leave a voicemail if they want as well. Then the person that answers, they will send a message to Cerner to the clinic, and then we will monitor to make sure that folks are getting answered by the end of every day. We also did find out today that there's a pool that we didn't know about for medication refills. So that was something that Cerner did not explain to us. So it's something that their medication refills were going into another pool that we were taking care of, but there is another one that I just learned late this afternoon. So now I think that will definitely decrease our call volume as well, because we've identified an issue that we can address very
Can we talk after? Because I only know the one, too. Please.
Because there's multiple different, yeah. And then for the IVHD transition, I feel things are going well. We have had a lot of meet and greets. The only directors that have not had a meet and greet is laboratory, which we hope to have them meet next week. Today, actually, we had the clinic directors and the managers and the CNO from ECRC. We did a full tour of Calexico, down at Tel Central, back to Brawley. We looked at radiology lab and multiple different areas. So very good site visit, and some things are moving forward.
Urgent care report to us. Number, do you see anything?
So we, as you can hear from the CNO report and the CCO report, there's been a lot that's been going on over the last little bit. One of the big things I do want to highlight, because I think it went really well, we did decide to do a joint NFL kickoff party kind of thing between the two facilities and two locations. And so people had the opportunity to wear jerseys that day. We had a wing eating contest that included both facilities and judges from both facilities. It was a lot of fun. It was received really well. And there is going to be some video. Some of you may have seen it already because I think it just dropped in that, so you guys could see those videos. But so it was received really well by the team, and you can see some of the conversation that was had there, that the staff liked the idea of doing that and being able to bring everybody together. So a lot from that standpoint that we're doing, and making that happen. On the other side of that, you've heard that we've had multiple visits between the two facilities, going to multiple locations. We've kind of put eyes on all of those spots to really get an understanding of what we have, and as far as our arsenal, if you will, for the different locations. And it is kind of very interesting because we have the Brawley location that has the hospital, and across the street from that you have most of the clinics, and then you have that's kind of really together, and then the Pete's that's down. So really kind of El Centro is kind of the same way. You've got the hospital and the MO. Figure out, okay, how are we gonna make some of this stuff work based off of the timing on these contracts? And so a lot of being looked into from that standpoint, so we can really map that out more appropriately for the organization as we move forward. So right along with that, we've had a lot of movement with PMA, which is, as a reminder, is our master planning group. We actually had a conversation with them yesterday and had them come out. Yesterday, they brought out some actual ideas and renderings to present to us to kind of look over and see what we thought about what they're. And so we've got that now. Next Thursday, we're going to have another meeting with them. So our team has a number of different meetings with the different areas that are going to be part of this process. Like today, we met with the pharmacy group, showed them the different options, went over like what their space requirements are and which ones they like best and why they like that. And we'll be doing that with each one of those groups until Thursday, when we have that meeting on Thursday with PMA, so that we can tell them these are the thought processes that we've had for this and what that needs to look like. We also spent a lot of time with them talking about some of the financial constraints associated with this. So as they're very mindful as we go through this process, like, yeah, like for example, one of the options is the bells and whistles option, and it really was a bells and whistles option. And that was the option that we would have taken, had Dave won the lottery, but he did not. And so we don't have that option, realistically as one of ours. Because we're also mindful of the fact that some of these changes that we'll make on there, if we do those changes, then that's like the facility for the next 50, 60 years. As opposed to some of the thought process that we want to be mindful of as we bring this to the board, where we're saying, hey, the thought process before was potentially like a hub and spoke model, where we could have a central location for the hospital, and then we have these spoke models if things change within the state of California, to be able to have a standalone ER setup, so we can have those in those outreach locations. So we're trying to be mindful of the future piece of that, and then of course also very mindful of the dollar amount that we're spending. With that being said, the 23rd of October, they're going to present on the 13th of November, the plan, right? That's going to be the recommendation. On the 23rd of October, this is Pablo's idea, is a great idea to have them come ahead of time and be able to have the conversation with you guys about like the difference between the SPC and the MPC and what that means, and understanding why we have to make some of the changes that we have. So they're not doing that at the same time as you're seeing what's happening. So you'll have a better understanding of the process before you see that, and that will help that go along much faster, or much better. So just be mindful of that. That's going to happen on the 23rd. We'll put them on the agenda to come out and have that conversation, and have you guys have that opportunity to ask questions of them at that time. So that's a book, my report. Unless you guys have questions, I'm more than happy to answer. Thank you guys. Yes.
We have no finances. No finance, right?
Yep.
No. Adjourn.
No report today.
Awesome. And then items for future agenda, I think.
And for,
Let's go.
fire chief control.
Do you want that on September 30 or October 9?
It's a special meeting, if we don't present on special meeting, or?
You can do anything at a special meeting other than executive. It's just a matter of what you want the meeting to look like.
Let me, get in touch with them and see which date. Because I believe we talked about.
Yeah, October 9 is the next regular board meeting.
Has he reached out to either Pablo or Chris?
I don't know. I don't think so.
No? Okay.
I have.
Not 60.
Okay, if I ask.
Yeah.
To go with them? Okay.
So I had a conversation with one of their council members and had directed him. So.
I think that part of that conversation, needs to be had with regard to something that we've discussed on the board all the time about the main issue of the hospital on wheels issue, you know what I mean? So that's gonna, it's a nitty gritty on it.
Yeah.
That's not used anymore. That's what it will.
So, anything else?
Well, what I just talked about too, adding, if we can add the PMH or the PMA presentation on the 23rd, October 23rd.
Perfect.
Next have a special meeting, do you want August financials and for next, okay, I will make sure that we're.
It's gonna make it really big.
It's not overwhelmed.
Yeah.
Okay. Perfect. With that, we're going to close session at 7:37.